off the big toe off, but their left foot is almost like it's turning it in and almost looking to drive. It's almost like they're trying to drive through that little toe. Now, just trying to wonder what's happening there. They, like, the way I've addressed it is if he finds his left glute, then he's able to drive better. However, I'm trying to think with the framing of the principles that you're telling us what's happening.
So you're saying this is an individual who they're doing a sled drag or a sled push?
Push. So sled push, and they're left, basically it looks like they're really like properly pronating and pigeon toeing to go on the outside of their toes rather than driving through the big toe.
Yeah, I think, so when I see a foot that's turned out, for example, I think I mentioned this last week. When I see this, that's a foot.
Other way.
Yeah, exactly. So they're doing this, right? So this is a foot trying to find pronation, in my opinion, because their foot is probably very high arched, and this is the way that they can best hit the ground, go into pronation. So I think the inverse of that would be a foot trying to find supination. So if we think about what the left foot likes to do, it likes to be very pronated. So I think what's going on there is they're probably turning it out so that they can resupinate that foot and then get back into a gait cycle that works best for their restrictions.
Cool. And then, thank you. And the second one was, there was a couple of questions that came up on the Slack chat, and it's just trying to understand where the understanding of things are. So it was deadlift. So a normal conventional deadlift. My understanding was, so where I was thinking about it is that the eccentric part of that is more of a loading and early stance, whereas the concentric is moving towards a late stance / toe off. And that's where we're talking about, driving through the big toe to get the concentric moving forwards, because it's hip, it's a propulsion move. Mm-hmm. However, a couple of the guys were saying that it might be late stance to mid rather than mid to early. It's just, again, tying myself up and understanding what the right answer there was. Now I know it can be influenced either way, so biased, based on how you've got your foot placement and that type of thing, but it's just trying to understand what that would be if we just take the deadlift as an example.
Yeah, I think it's kind of similar to the squat. And actually, we can draw some good parallels here. So I think loading onto the heels is a very good strategy, because if we think about what heel strike is, it's an eccentric strategy. Being on your heels, kind of an eccentric strategy. So that's why when we go down, like let's say we're at the top of a deadlift, like we're standing tall. Same thing with a squat. When we go down, we're going to load onto more of our heel. That's good, because that allows for that eccentric activity to occur. And then when we're in the bottom position of a deadlift, we're here, so we're going to have to nutate. Now, since we're still on our heels, we're going to have to then start to propel or pronate. So because we're in this nutated position, it works quite well, because we can then seek a pronation strategy to propel ourselves upward and then complete the rep at the top. A squat's very similar. So in the middle half of a squat, or really like the parallel squat, that's the point at which we also want to pronate and create that propulsion strategy. So I think it's very good if we load on our heels, assuming our whole foot is flat. But I think pushing and then starting through pronation, which should happen naturally, honestly, it shouldn't be something we have to coach. I think that is what we're looking for. And then I guess you could make the argument that we're going to finish on more of our forefoot, like the big toe, but ultimately we should still have our whole foot flat on the ground. So we kind of go from like the early, we still follow like the gait cycle. It's just in a bilateral, you know what I mean?
Yeah. Okay. So, and I'm right in saying, because like let's say above the knee to lock out, going concentrically, so lifting it up. If you look at that from a limb arc model, then you move more into, like, you're becoming more externally rotated, but not necessarily in full external rotation.
Right. Yeah. Okay. You're going to start in a nutated position. Yeah. And then you're going to end in more relative ER.
Yeah. Mm-hmm. Cool. Thank you.
Of course.
For the AFIR, AFER exercises you gave, I asked you on Instagram about them, but I was a little bit confused. Like, what would be an assessment finding that where like you would prescribe one of those exercises? Because I thought, like, I've been just playing around with this stuff, and I thought that I was gonna need the AFIR. I did it, and like, man, my hip felt like crap. Still, like, even today, I did it like 3 days ago, and I'm still like, it just felt like the femur was like pinching the inside of the acetabulum. And so then I just did a bunch of external rotation and like anterior pelvic tilt stuff, and it seems to feel better. But yeah, I was like, whoa, it kind of worried me, because if I ever gave that to a client and like, yeah, my hip felt like garbage. So I was like, what would be an assessment finding that I would know whether what I'm prescribing and why?
Well, yeah, it just wasn't the right thing for you at this current moment. Are you narrow or wide?
ISA?
Yeah.
I would say I'm a wide ISA.
Yeah, so that actually might be pushing you really far back into your hip even further. If you are not heavily compensated, you probably, AFIR is probably pushing you further into where you already are, because you're doing this with AFIR. So if you're wide and you're nutated and already forward and you're driving more of that, that's probably giving you probably a little too much of the direction you're already biased to. So that's why doing hip ER stuff helped you feel better, is because it helped you get more neutral. That's just my guess. I don't know. I haven't assessed you.
Yeah, I know it's so tough, because when I do the knee lift, like the side, the 90-90, like the knee lifts, you know what I'm talking about, where you slide like my left side was really like, it was impossible at one point, and now it's like, it's still weaker. So I just assumed that I would need the IR. I don't know why I jumped to that conclusion, but maybe if you could help me make sense of how you could be weak in that exercise, but then, like.
Well, it depends on like the level of hip flexion that you're in. We'll get into this when we get into the corrective exercise progressions and also exercise selection, but AFIR is just really a hip shift. And a hip shift is ER or IR, depending on where you are within the Lemmark model. So if you're in 0 to 60, that's going to be more of an ER. When you do that hip shift. And then if you're going to do it in more 60 to 120, it's going to be more IR. I think that's, if you guys follow kind of like that realm of social media, like that's talked about quite frequently. So it depends on when you're doing it, and it depends on how you're doing it. So I'm not really going to be doing any hip shifting activities for most people the first phase of a program, unless I know they're like a primary or like early secondary strategy. It's just not usually worth it, because I'm going to spend a lot of time doing bilateral things, getting them cleared through, shutting off those bigger muscles closer to the surface that are compensators. So you may have gone into that too early, and you might have pushed yourself further into where you're trying to get out of, and therefore your hip was irritated. Now, if you're in a left AIC pattern, you're in a true left AIC pattern. We verified that through an assessment. For example, you're doing an Ober's test where you have a pass on the right, but fail on the left. Then that would be an indication that we could then do some sort of activity like that on the left side, because that's what the left side is usually lacking. But I would not do that if you're just day one with me, probably. Does that answer your question?
Yeah, thank you.
Cool. Anything else?
Bringing back what Rich said, I started the thread about the deadlift and the squat. And so you say there's no difference between both of them. For when I mentioned that in the chat, is because I think about the deadlift more like a posterior to anterior. No, I mean, how to say it in English? Like the ground reaction force goes more posteriorly in the deadlift than in the squat.
Sure. Oh yeah, no, they're two totally different exercises, but the strategy at the point in the Lemmark model is going to be similar. So when you're nutated in that 90 degrees of hip flexion and you're driving through the floor on the concentric, that's when you would want that pronation to occur and more weight to translate forward. And same thing for the squat when you're at 90 degrees. But in both, you also want to load onto relatively more of the heel. But they're two separate exercises in different contexts within like what musculature they're recruiting more than others. So, you know what I mean?
So you wouldn't relate them with gait cycle. You would relate them with other stuff.
Oh no, I mean, like the Lemmark model to me is the gait cycle. So like, think about it. Heel strike is very eccentric, right? So we load onto our heels on those exercises, which makes sense because that's heavily eccentric. Then after we start propelling, that's going to be that would be going from heel strike to mid stance. which would be more of that IR activity, because we need a propulsive strategy to get that weight up, whether that is in a squat or a deadlift or a split squat or a single leg deadlift. The strategy to get the weight up is going to be heavily based on IR and the ability to bring that foot into more pronation, the ability to essentially just transfer from ER to IR back to ER again, or IR to ER, depending on what the exercise is.
What I meant is that if you have someone who's stuck in heel strike, doing deadlift or squat, it wouldn't be one of the choices. You know what I mean?
Can you clarify that?
So if someone is lacking late stance or heel strike, would you choose one or the other? Or in this case, it doesn't matter which one it is, or it's not one of the main reasons why you choose one of them?
I see what you mean. Yeah, so wides are going to be better at hinging. They're going to be more biased towards that mid stance. So I would probably want to give them more squat-like activities to bias them towards heel strike more, because squats are more ER heavy than hinges. Hinges are more IR heavy. So a narrow is going to be biased more towards early stance. So I probably want to give them more hinge-like activities to help bias them towards more nutation and IR. If they're late stance, then I probably want to bring them back to mid stance first, then back to heel strike after that. It's hard to make the jump from toe off all the way back to heel strike, because they probably do need to get some good IR back first.
Okay. Thank you.
And then James commented, I could be wrong about this, but hip flexion at 90 degrees, whether a hinge or a squat. Yeah, exactly. Yeah. And I'm going to, you guys know how I can mute everyone in the, I've been trying to figure out how to do this. How I can mute everyone. Oh, there it is. Okay. So now everyone's muted. Does anyone have one more question or anything else before we start? All right, let's rock and roll. I can always answer anything at the end. So we're recording, we're good. I'm gonna share my screen and then we'll get rocking and rolling. So today is all about the thorax. So what we wanna appreciate today is the anatomy and biomechanics of the rib cage, shoulder girdle, scapula, and humerus. We're going to understand how proximal structures at the rib cage influence distal position at the shoulder. And we're also going to appreciate the role of scapulohumeral rhythm, because that's going to be a huge indicator in how we go about restoring movement options. Appreciating that is going to be absolutely huge. If you guys watched my webinar on the upper body exercise selection, I went into this stuff a little bit, but I'm going to go into more detail today. Because that was just a basic overview. And if you want a more basic overview of these concepts, I'd recommend you go watch that. It's probably a good complement to this. And then we're going to understand the asymmetrical trunk position that we get into as a result of this left AIC pattern that is underlying us as humans. So first and foremost, I just want to review some basic anatomy, because the upper body can be a little bit more confusing in terms of musculature orientations than the lower body. So I just want to review some basic stuff, and then we'll get into some muscular orientation position stuff. So the shoulder girdle is made for mobility. Obviously, it's a ball and socket joint, just like our hip. So because it's made for mobility, it's going to sacrifice stability. And that's just the trade-off that happens within the human body. So if you look at the glenoid fossa and the humerus is like a pretty big bone, and it's like a golf ball resting on a quarter. So that is a pretty small surface for this humerus to glide on. So shoulder problems are usually really common because this thing is very inherently unstable, but there are structures around it that helps us stabilize this joint. And something that is absolutely essential, this is extremely important to understand if we're going to get anywhere with this presentation and these concepts, is that the scapula, I don't know if you guys can see it, but I feel this groove in here. It is a concave structure, meaning that it's rounded inwards. And the normal human spine has a degree of flexion at the upper back. So that's going to mean that it is a convex structure. The analogy I like to give is imagine two C's flipped backwards and stacked on top of each other. It needs to glide like this. So if you have a flat thoracic spine, you're going to be in trouble because that scapula has got nowhere to go because you can't get the expansion necessary in your upper back. And then if you guys want a little fun tidbit, you can look at the long head of the triceps here. Everyone's concerned about the upper back muscles when it comes to shoulder health, you know, like 2-to-1 pull push ratio, which never works. But look at this right here, this long head of the triceps. I want you guys to visualize this now, because you're going to see how when this contracts, it's going to pull the scapula down and in, similarly to how a pelvis attaches on the posterior structures on that ischial tuberosity to do the similar thing to that innominate bone. We've seen this slide before, but I want to go over it again because it's going to be even more relevant this week. So when we inhale, that's going to be B right here. We're going to get a little bit taller. We're going to have upper cervical extension, lower cervical flexion. Thoracic kyphosis is going to decrease overall. We're going to have that counter nutation of the sacrum that we're all familiar with at this point. And then the scapula is going to go inwards. Okay, so this is when we're going to get into that aspect of things. And you can look at this and say, all right, we've got ER, abduction, downward rotation, and posterior tipping. So that looks like external rotation is going to be this action right here. Abduction is going to move out, and then downward rotation and posterior tipping right here. So you're going to be here, here, and then down. I wish the scapula model had a rib cage to go on it, because then it would be much easier to see. Exhalation is just the exact opposite. And the scapula goes outwards, which is interesting. But if you think about what the scapula is trying to do, it makes more sense in this context. So the scapula goes outwards because it's like, imagine it trying to compress the rib cage and squeeze it together to get the air out. That's essentially what's going on here. So it's going to IR, and it's going to come around to help you squeeze yourself together to compress the air out of your rib cage. Then you're going to have that anterior tipping. Now let's get into some muscle stuff really quick. So the muscles I have bolded are the ones I really want you to know, especially where they attach, because that's going to be very important for when we talk about the chambers of the rib cage. So we have our levator scaps, we have our rhomboids, and we have our pec minor. You guys can look at the upper right here, and you can see how that would downwardly rotate the scapula. These muscles are really important when it comes to scapulohumeral rhythm. So I just want to give you a brief overview and get this kind of in your head of how these muscles work and where they're located and how they act together. The low traps are a big muscle that spans pretty much from T6 to T12. The lats are going to be a big player in this posterior tipping and depression. And the pec minor is also, interestingly, going to play a role in the depression as well, because it also has that downward rotation moment. So notice how, think about your big hunky powerlifters, right? They're going to have these pulled down scaps a lot of the times because their lats are overactive. Lats are one of those muscles that's close to the surface. It's massive, and it loves to compensate and stabilize when we don't have the movement options available to us. And then hopefully these little diagrams give you a good visual of how these muscles work with each other. The external rotators, I really want you guys to pay attention to these external rotators right here, because these are going to be massively important for scapulohumeral rhythm, especially as it relates to how they're going to work as the scap upwardly rotates. So just pay close attention to where those mid traps attach, where the rhomboids attach, and where the serratus anterior attaches. The serratus anterior, we think of that muscle and we think of it as something that protracts the shoulder a lot, and that's great, and it does do that, but it actually is heavily responsible for keeping the scapula on that rib cage. So what that serratus is trying to do in scapulohumeral rhythm, as we will see later, is it's trying to compress and keep this scapula from coming off of the rib cage. So if you see a wing scapula, you know the serratus is probably not doing its job very well. Upward rotators are going to be the upper traps, low traps, serratus anterior. Internal rotators are primarily going to be the deltoids with the posterior and middle fibers, and then the pec minor as well. And then I'm going to go through this pretty quickly just so you guys can look at this stuff later if you want. Upper traps going to be C7 through the clavicle. Levator scaps are going to help elevate and bring that scap upward, and also the rhomboids. These rhomboids are all over the place if you haven't noticed. As for humeral external rotation, we've got the infraspinatus, teres minor, posterior deltoid. These are just, we're getting into the rotator cuff now. But these are going to be less important for this model than the muscles that affect the scapula. And then the IR muscles of the humerus are the subscap, lats, teres major, and anterior deltoid. Okay, with that out of the way, let's now get into a little bit of biomechanics. We've seen this slide before too, but this is going to be, again, really, really important to understand before we get into things. So within the respiratory movements of the rib cage, the upper ribs, the pump handle ribs, usually 1 through 8-ish, are going to be operating as anterior to posterior expansion, front to back expansion, like a pump handle. After that, once you get lower, you're going to then run into these infrasternal ribs, these bucket handle ribs, the lower ribs, which are going to swing out and inwards as they expand laterally. Make sure you know that. Okay. Now, our wide ISAs, this always confuses people, so bear with me here. So we got to remember where the wide ISA is starting from. It's starting from a position of anterior expansion and posterior compression. So because that posterior compression exists, it's pushing the scaps back. And we call these wide ISAs exhaled people a lot, but it's just relative. Like you can call the narrow ISAs exhaled depending on what you're talking about. So these wide ISAs are compressed posteriorly. So that's going to push the scap back into external rotation, adduction, downward rotation, and posterior tipping. So it's going to be like this. So you can see, looking at this gentleman right here, how he would not be able to get much air going into his posterior thorax. So the humerus is going to need to then compensate into internal rotation to find what it doesn't have. So that means that the scap is being pulled back and down, but the humerus is going to turn inward to help him find internal rotation. So that's what happens originally. But I can honestly tell you guys that I have seen maybe 2 wide ISAs in my entire life that have more IR than ER, just because I haven't seen one person in my whole life that hasn't compensated to some degree. So you're usually going to see wides be limited in humeral internal rotation, just because people tend to compensate. But technically, they should have more IR than ER because their whole skeleton is biased towards IR. Narrow ISAs are going to be the opposite. Perfect example right here. Their anterior thorax compression is going to lead to the scapula being pulled forward and inward. That's why these people have such forward heads all the time, because their scaps are in internal rotation, abduction, upward rotation, anterior tipping. You can see how that spreads apart their scaps so air can travel into the back, but no air is going forward. So they got to have an inhalation strategy somehow. They do it via opening these scaps. So the humerus then, because everything's being pulled forward, they need to have that humerus turn out into ER so they can find ER. So that's what we're seeing when we refer to narrows as having more humeral external rotation than wides. All right, now these are what I refer to as the chambers of the posterior rib cage. These chambers are going to be really, really important basically for the whole rest of the program. So make sure you understand these. The upper, when I refer to upper, I'm referring to T2 through 4. When I refer to lower, I'm referring to T5 through 7. And then when I refer to below the scaps, I'm talking about T8 and below. So the upper portion of this is going to be consisted of the mid and upper traps, rhomboids, and upper parts of the serratus. So if these muscles are concentrically oriented all the time, we're not going to be getting much air there posteriorly. Likewise for the lower aspect, T5 through 7. And these are just where the muscles are crossing. So that's why if they're concentrically oriented, they're going to be preventing expansion there. The anterior ribcage chambers are the same. They're just on the front side of the body. So you're going to have your pec minor, your pec major, and lower pec major fibers through T5 through 7. Below that, you've got your infrasternal angle. So again, make sure that you really understand this. But notice how the upper chamber is much larger in terms of just like, diameter than the lower one when we're talking about the anterior. There's a lot of expansion going on there. Okay, now let's get into scapulohumeral rhythm. So when we lift our arm overhead, that's usually what we're referring to when we say scapulohumeral rhythm, because that's the best way to sort of visualize it. And we can also think of the limb arc model as this humeral flexion, just as we think of hip flexion as the limb arc model as well, like a squat. So let's visualize the limb arc model together using humeral flexion. So from 0 to 60 degrees, we're going to have mostly scapular internal rotation coupled with humeral external rotation. So the scapular external rotation muscles are going to be more eccentrically oriented at this phase from 0 to 60 degrees. That means our low and mid traps and serratus anterior are going to be eccentrically oriented, which means we can get air into that area. So whatever's eccentric, that means we can get air into that area of our rib cage. Whatever's concentric, we're going to have a much harder time doing. From 60 to 120 degrees, this is going to be more scapular external rotation with humeral internal rotation. So now those muscles I mentioned on the last slide are going to be more concentrically oriented, meaning that when we reach forward, especially at 90 degrees, more air is going to be going forward than it is backward, which is weird because when you visualize a forward reach with your ribs back, you'd say, wow, I got a lot of air going back, don't I? Not really, unless you're engaging your pecs. If you're engaging your pecs, then you're really closing off those anterior rib cage chambers and air is going to go backwards more, which is a strategy. I don't really cover that a lot because I figure you can just throw them supine if you want to get air going backwards just via gravity. But ultimately, if you are going to reach at 90 degrees and keep your pecs off, air is going to be going forward. And we will review that in just a second. And finally, from 120 to 180, the scapula is going to be in relative amounts of internal rotation. And again, it's relative to where it was before. And the humerus is going to be a more external rotation. Now, the kicker here is that at this point, the scapula is already pretty upwardly rotated. So what it needs to do is it needs to tip back on the thorax to allow for that final degree to happen, that final little bit of shoulder flexion. But if we have a compressed and flat thoracic spine, that's going to be very, very difficult. It's going to be hard for us to get that humeral flexion to 180 degrees if that scap can't tip back. But this is also going to eccentrically orient our pecs and lats. So if we're trying to drive air into those areas, it might be a good idea to reach overhead. I have a lot of wide ISAs reach overhead first to the degree of shoulder flexion they can maintain, because that's going to shut off their pecs. If they can't shut off their pecs, doing other degrees of reaches. So because of all these things, the upper parts of the sternum are going to get more air, especially in that T2 to T4 area. The cervical spine is also going to be a player in this. I have some exercises that you'll see where I turn my head to the side while doing it. And that's because after about 120 degrees, there's a slight cervical rotation to the same side, which means the facets are going to face the opposite direction. So if I'm reaching my right arm overhead beyond about here, my cervical spine is going to slightly turn to that same side, which is going to turn the facets to the left. So I'm going to get more expansion on the right side. And this can actually run all the way down to T4. So if we're trying to get air in the uppermost portions of the rib cage in that T2 to T4 area, it would make sense to add a slight head turn with a reach over 120 degrees, assuming that's not going to torque their neck and they're ready for it. But even a slight rotation can make a difference. So manubrium and sternum. These are two, people think of like the sternum as one big thing, but it's really not. So the manubrium is really more associated with the T2 to T4 region, whereas the lower rib cage is going to be associated more with the sternum. So you can think of T5 through 7 as more sternum and T2 through 4 as more manubrium, relatively speaking. And one can be in flexion and one can be in extension. So you can have a manubrium. I think the next slide has an image. Yeah, so look at the manubrium right here. So if this is my manubrium, this is my sternum. The manubrium can be down while the sternum comes up, and you can have the opposite orientation happen as well. So I actually have a client right now who is, he's a rugby player, and he has a depressed manubrium because he was, I think he was like punched there once when he was playing rugby on accident and just like indented it. So his manubrium is down and depressed while his sternum is excessively risen, which changes his biomechanics of his thorax. So we need to do things to drive air into that aspect of the rib cage, because that is the limiting factor within his movement. And then you have the xiphoid process down here. Okay, let's run through a couple of things really quick. So let's do this. Let's all stand up, and we're going to do a couple different reaching activities. All right. So what I want you to do first is I just want you to stand normally. And then I want you to stand with your feet hip width apart, toes straight ahead, unlock your knees a little bit, tuck your hips. You can give yourself a quick 1-2 really quick. This is not a accurate way to do it, but just see what your your external and internal rotation feels like. Make sure your shoulder doesn't come forward or backwards. Give yourself a quick 1-2 on both sides. See what your shoulder flexion is. Just kind of feel it out a little bit. Feel how stiff you are right now. Okay. Now, tuck those hips, find your heels. See if you can get your hamstrings to kick in a little bit. Now let's do a downwards reach like this. Give yourself a downward reach, not past 45 degrees. Exhale through your mouth as you would relative to your ISA strategy. Pause. Inhale. Exhale. Give me 5 breaths in that position right there. Feel like you're getting all that air out. You're keeping your position, keep a neutral pelvis. And then if you're a wide ISA, make sure you're keeping those obliques on when you inhale through your nose. If you're a narrow, make sure that you're exhaling through your mouth with a big open fog. And you can keep a slight degree of ab tension, but not as much as if you were a wide. So do like 5 good breaths there, and then relax. And then play around with your external rotation on both sides. See if it doesn't feel a little bit more loose. Play around with your shoulder flexion a little bit if you did 5 breaths. Things should feel a little bit looser. Okay, now we're gonna do one for internal rotation, okay? So internal rotation is anterior expansion, as we're gonna review soon. But we're going to get in a quadruped position because that position is working with gravity. So gravity's pushing down on us. So if we're in an all fours position at a 90-degree reach, that should, in theory, help us clear up some internal rotation. So let's get on the floor. Knees underneath your hips, hands underneath your shoulders. Unlock your elbows ever so slightly. And then most people will mess this up by rounding their back too much. If we round our back too much, we're going to depress our sternum. So keep a neutral spine and slightly tuck your hips. Lean over your hands ever so slightly. If you look at me, I don't have a big back arch or a big back round whatsoever. It's just slightly tucked. And then breathe for 5. Hang out there and just breathe. 5 good breaths. And I'll honestly say, while you guys are doing this, a lot of people will be in the perfect position. You'll coach a lot of people that look really, really good, but you'll retest them and their measurements aren't any better. And it's probably because their breathing just wasn't good enough, meaning that they weren't exhaling long enough or they weren't inhaling. So just a little tidbit for you guys. I would recommend that you, before you say the exercise was the issue, consider their breathing. Were they inhaling long enough? A lot of people are so focused on the exhale. You got to think about the inhale too. If the inhale is not long enough, they're not going to expand. After that, stand up, see what your internal rotation feels like. Should feel a little bit better. Maybe on your left side might improve more than your right. That would be normal. All right, got some blood moving. Let's sit down and let's get through the rest of this guy. We'll do one for upper at the end. So as I just mentioned, if we have a loss of humeral internal rotation, that's going to be a loss of expansion of the anterior inferior rib cage at T5 through 7. Because those ribs are going to be compressed and it's going to not allow you to, that's basically going to prevent expansion from happening there. And if you're already biased towards IR, it's going to be hard for you to get into more IR. Same thing for a loss of humeral external rotation. That's going to be in this region right here, restriction. Humeral abduction is going to be a loss of expansion in the anterior and posterior inferior rib cage. The reason for that is that concentric orientation of the musculature on those sides. So if you have really tight pecs, it's going to be really hard for you to abduct your humerus. So that's why it's both anterior and posterior. Adduction is going to be for a very similar reason. If you have really tight pecs, or if you have really tight rhomboids, or any of those muscles in that region, it's going to be hard for you to adduct. So that's why it's hard to differentiate between A to P here, but it's still important. So you can use that along with shoulder flexion, like we'll talk about next week, in order to determine where that restriction is. But these are the 4 tests I like to use to isolate where the issue might be. So don't worry if you don't know how to measure these yet, that's all next week. So if we want to have a select reach for expansion, this is what we're looking at. A lower reach, like we talked about in scapulohumeral rhythm, is going to give you more posterior lower. It's going to give you T5 and just pretty much below that. You're going to get expansion below the scaps as well. You're also going to get some upper expansion, and this is something some people miss. Think about what happens when you're reaching down at 0 degrees. You're going to be eccentrically orienting a lot of the muscles in the upper parts of your back, and also your chest if you can keep your pecs on. So maybe a good way to drive air into the upper rib cage, if a higher reach isn't working, is just do a lower reach. And then a 60 to 120 reach, you can argue that you're getting some upper posterior and lower posterior expansion, which you are, but I'm just trying to keep things pretty simple. But it's mainly going to be that anterior expansion, primarily at T5 through 7. After that, once you get above 120 degrees, you're going to be in more of that anterior to posterior upper expansion because of those principles of scapulohumeral rhythm. And you're also going to be getting some expansion below T8. Because remember, all those muscles on the sort of mid back are working to upwardly rotate the scap, and it's also posteriorly tipping. So those scap ER muscles are going to be still a degree of concentric orientation. So you're going to be getting air going below the scaps, but also you're going to be getting some air going in the uppermost regions of the thorax. But you're also going to have that occur anteriorly as well in the uppermost regions, because the pecs and lats are eccentrically oriented. So this is going to be a massively important thing for you guys to check out and understand for the rest of this program. I would save this slide, print it out, put it on your fridge or something. So now we're going to get into a little bit more intricacies. When we pronate and supinate our hand, different things are going to occur at the scapula. For example, if I were to pronate my forearm, right? Let's look at what happens here. Pronate. That's going to bring my humerus into internal rotation, which is going to externally rotate, relatively speaking, my scapula. So that is going to close off and bring those scapula closer together. So air is going to be driven forward more relatively than if I were to have a neutral or supinated grip or reach. Because when I supinate my grip or reach, I'm going to be doing this, which is going to bring my scapula out with it into internal rotation. So a supinated grip is really good for getting posterior expansion. So maybe if I wanted to drive air and maximize it into my anterior rib cage, I'd do a 90-degree reach with a pronated reach. Or if I wanted to maximize posterior expansion, I would do a low reach with a supinated reach. And we already did that a little bit earlier. So let's go into the influence of trunk rotation. Now, this is when things can get a little bit tricky, so just bear with me. This is the week where people can feel a little bit overwhelmed. So I just want you to know that that's normal, and it gets a lot easier after this. So when we have trunk rotation, when we rotate our trunk to one side or the other, that's obviously going to influence what our scapula does. So let's say I rotate my trunk to the left. What's going to happen is the left scap is going to go into adduction, external rotation, downward rotation, and a posterior tilt. Unfortunately, this is a right scap, so it's hard for me to show you that. but essentially it's going to come more inwards. The right scap, on the other hand, is going to go into more internal rotation. It's going to come more outwards and anteriorly orient. So basically the left, when you rotate your trunk to one side, let's say I rotate to the left, my left scap comes back and my right scap comes forward. Now, if we were to couple that with a degree of humeral flexion, that's obviously going to change things, right? So let's say I'm reaching like I am right here. I don't really care about showing this video. It's just, you know, a basic exercise. So let's say, like I'm doing in this video, a right reach with a left trunk rotation. What I'm going to be doing there is, because I'm at 90 degrees, I'm going to have a relatively more externally rotated and upwardly rotated scap above 60 degrees. But my spinous processes are also going to turn right because I'm turning my trunk left. So imagine my spine is pointed straight out, right? So if I rotate my trunk to the left, the spinous processes are going to go right, which is going to close off my right posterior rib cage more so than the left, because the left is now opened up. But I'm reaching at 90 degrees here with pronation, so I'm going to get more anterior rib cage expansion on my right, more posterior rib cage expansion on my left. I know that's a lot, but just study this stuff. We can go over tons of stuff in the review session. Just to make things simple, just no scapulohumeral rhythm. So if I'm going to reach at 90 degrees, air is going forward, and then think about what that facet is doing. Think about where the spine is going. That's going to be a big indication of where air is going to go. Okay, with that all in mind, now we're going to couple this with asymmetry and where this left AIC pattern comes into play. So we've already seen this picture. We know that the right diaphragm is bigger than the left diaphragm. So the left diaphragm can go into a descended state and stay there, whereas the right cannot as easily because it's really sitting on top of that liver. So it's hard for it to do that. But air from the right diaphragm goes into the left lung and it expands the left lung. So we call this pattern the right brachial chain. Don't really care if you guys know what that is necessarily. Don't really care if you know these muscles. But I just want you to know that when we're referring to what's going on with the left AIC up top, it is the right BC. So when these muscles get tight, these chains of muscles right here that runs in our thorax and neck, it's going to concave our chest more, reduce lymphatic drainage, and restrict anterior lobe expansion, basically just anterior expansion in general, and limits trunk rotation to the same side or lower half to the other side. So basically what that means is that it's going to restrict trunk rotation to the right, and it's going to restrict pelvic rotation to the left, which is just the inverse of a left AIC position. With this right BC, what you generally see is a right shoulder that sits lower than the left. So when I see a left shoulder that sits lower than the right, I know I have a compensation. In fact, I can't really think of one instance where I've seen a lower left shoulder and there wasn't a compensation there. So the right anterior chest wall is going to be compressed and the right expanded. Why? Because our trunks are rotating to the left. So that's why I used that example from earlier, because that was pretty much the inverse of what we're talking about here. So let's say we got, well, actually I did use the left trunk rotation example. So I'm rotating to the left, my right scap comes forward into more internal rotation. We're going to visualize this in a second. The left is going to come backwards. So we're going to have less posterior expansion, more right posterior expansion, more left anterior expansion, less right anterior expansion, because you're here, open, closed, close, open. And this is all relative to what your ISA is, entirely relative. So like I mentioned, the right scap is going to be in an orientation of internal rotation, abduction, upward rotation, and anterior tip, just like I mentioned on the influence of trunk rotation slide. So that's because of this left trunk rotation, which is going to open up our right posterior relative to the left. The primary needs of this individual is a low trap, a tricep, serratus anterior and internal obliques on that right side, because that's what's going to pull that scapula down and back. But none of this matters if we can't clear things bilaterally first. I just want to make that really clear. I'm not worried about this stuff until I clear them and I kind of get them out of their compensation patterns. Their secondary and tertiary meaning. The left scap is going to be an adduction, external rotation, downward rotation, and posteriorly tipped, just like that. So that's going to close off air from going posteriorly. So they primarily need an external oblique on that left side and also posterior expansion on that left side. Now, we've talked about asymmetrical ISAs a little bit, but the reason why we need an external oblique on that side is because the left tends to be higher than the right because of this orientation right here, which opens this up. So that external oblique needs to kick on to bring that down. Posterior expansion will also allow that to happen. So because of this orientation, what we expect to see is all those things I just mentioned through T2 through 7. So I would expect to see less right humeral IR, less right humeral adduction, less left humeral external rotation, less left horizontal abduction, mostly because that left pec is really tight and pulling and preventing that abduction from happening. And usually that right pec minor, which is pulling that right shoulder forward, is also really tight and restricting that adduction. So in terms of breathing through these exercises, I think we've gone over this already, but I want to just drive this home. When we're cueing someone through breathing, let's do this together. So I like to cue a relaxed belly, a jelly belly, because if you're very tense through your stomach, if you have your six pack on, but not your obliques, that's a big issue. So we want to make sure that we can relax our belly. And then the exhale is going to happen as a result, or the obliques coming on is going to happen as a result of the exhale rather than a conscious recruitment of those muscles. Then we want to pause for 5 full seconds if possible. Most people won't be able to get there right away, but we want it to be about 3 to 5 seconds. And then inhale slowly through your nose without your lower ribs coming up or shoulders coming up. When I was learning PRI, when I was first starting out, I had a boss, and this guy was brilliant. I don't know if any of you guys know who Jennifer Poulin is. She teaches myokinematic and pelvis restoration. Her husband is just as smart as her. And this guy he told me on day one, I will do anything to get a zone of apposition. Zone of apposition just means ribs stay down. We don't go into that because I don't think that term matters for what we're doing. I mean, the concept matters, but not necessarily the term. So if they need to keep their ribs down, and he'd say, I don't care what else they do. They can kick their neck on, they can get their neck forward. Doesn't matter. I need those ribs to stay down so that they can sense that expansion. Which to me, I was like, oh man, that's interesting. I wouldn't imagine I wanted someone's neck to kick on, but he's realized that getting those ribs down and keeping those ribs down is the primary focus, and it needs to be the primary focus. You can get someone to adjust things later on, but just getting them to sense that right away is massively important. So let's see if we can do that right now. Sit nice and tall or stand nice and tall. Link your hands together on your low ribs like this. And then exhale through your mouth with a neutral pelvis. What I want you to focus on more than anything else is keeping that slight degree of abtention and not letting your lower infrasternal ribs rise much more than they are right now. See what happens. You might feel like you're suffocating a bit. That's probably because you can't expand very well. So keep that down. Pause, inhale. See if you can do that without your shoulders coming up or low ribs coming up very much. They will come up to some degree, and that's totally normal and healthy. But if you're shrugging or those ribs are flaring, you know you've lost that zone of apposition or keeping your ribs down. It's tough. It's really tough. Okay. Here's a couple of examples of exercises that can illustrate what we're going for. And again, these are just your super basic exercises. These are nothing fancy at all. Wall supported downward reach. So I'm putting that ball in between my legs. Just, it's optional. You don't need to do it. Probably do that with more of a narrow than a wide. And then you want to have your low back on that wall or whatever it is. You want to make sure that your upper back stays off and that back is serving as a reference for that posterior pelvic tilt. Reach down and then just breathe. We kind of already did this one earlier on, but this would be good to get some low and upper A to P expansion. This one I love, and this is the one I want us to do right now because this is fantastic for that upper rib cage expansion, and it's a wonderful illustration of what's going on with that cervical rotation. So here, I'm gonna push the floor away, and I'm gonna bring one elbow out and pull my butt away from my elbow. With each exhale, I'm gonna feel myself do that more and more. And then notice how I'm gonna turn my head to the same side so I can get that same side cervical rotation. Doesn't have to be anything crazy, but the hardest thing for people to do here is do this and not shrug their shoulder up as they do it and turn their head. So let's do this together right now. See what your shoulder flexion feels like on that side. Give it a little 1, 2. See what your internal rotation feels like on that side. See what your A deduction feels like on that side. All right, let's get back in this position now. So the starting position is here. So you want to start in this sort of child's pose position with your hips flexed and your forearms and your tibias on the floor. Good. Now pull one arm or one elbow ahead, kind of like this right here. And then think about anchoring that elbow to the floor and pulling your hips away from your elbow. You should feel that stretch in your lat immediately. Keep your shoulders out of your ears and then turn your head to that side and breathe in through your nose, out through your mouth. Feel that expansion happening. Try it on both your left and right side after do like 3 breaths each side. Focus on keeping those ribs down. Some people have trouble feeling this because their lats are literally just that tight. And some people don't feel this at all because it's not the right exercise for them. But I find this is an enormously helpful exercise for 90% of people on day one, pretty much regardless of where they're starting from. Most people have their lats on to some degree. All right, get up and then see what's going on with that shoulder flexion. You should notice a difference in your shoulder flexion. And you should notice a slight difference in your internal rotation. It should feel a little bit less sticky. If you don't, we can talk about it. Maybe you'd make a good case study. All right, this next one, I have no idea what just happened right there. Let's see if we can fix that. That's janky. Hang on. Whatever. Okay, we're just gonna roll with it. So you guys can kind of see that, I think. So notice how I'm in the inverse of a left AIC pattern here. So I'm gonna have my right leg out in front. I'm gonna have my left leg behind me, and I'm gonna have my left hip in extension. And then I'm going to be side bent to the left. So this is gonna close off my left and is gonna open my right. Now, when I do this, I'm gonna think about pulling my knee down and inwards towards me to get that left adductor on. And then I'm gonna drive my right knee into the floor, which is going to allow me to get that ER on the right side relative to the left. And then I wanna stay nice and upright as I inhale, exhale, and feel that right ab wall expand. This is another one I think we should try together because this is just a good activity for people to sit in if they're in a left AIC pattern. So let's hop on the floor and let's give this a try too. Maybe I can open this up on youtube.com. There we go. So right here, drive that left knee down and in to get yourself that left adductor. That left hip should be perfectly out from your hip. You should have a pretty straight line from the top of your head on the left all the way down through your knee. Should be pretty straight. And then the biggest mistake I see people make here is they will lean too far to the left instead of staying relatively upright. You want to make sure that you are leaning to the left, but you're not really awkwardly torquing yourself. So feel that left adductor, drive that right knee down. Inhale, and you should feel your right ab wall expand. Exhale, and feel your left abs engage and compress. Pause with your tongue on the roof of your mouth, and then inhale through your nose. You don't have to do the tongue thing. Honestly, I don't really cue it. That was honestly just kind of habit. But I don't really cue it because it's just another thing for them to think about. And I don't know. I haven't noticed that big of a difference with people. And then do about 5 breaths there. You should really feel that right ab wall expanding. Another thing people will try to do is overextend their back. So make sure you can keep a slight degree of thoracic flexion. Keep your stack. You should feel that left adductor working the whole time. All right, how was that? Hopefully you guys felt that. Some people don't feel the right ab wall stretch as much because they're wide, but narrows will feel that. Okay. And that was it for this one, but I'm sure you guys have some questions, or at least I hope you do. So let's chat a little bit about this week. Oh, I'm sorry, I didn't see these questions. Are you protracting with other arm? I'd be sorry, Kim. I'd be curious to know what you were referring to there.
For the rock back lat stretch, are you like pushing the floor away with the forearm that's flat as this elbow's forward, or are you just kind of passive with this other arm?
I'm pretty passive, but if you're good, you can protract it, and I find it helps, but I usually don't cue it very much. Anything else? This week can be confusing, so I want you guys to know that if you're confused, it's normal. This week is confusing for people. What's up?
In the left eye, I see we need more posterior expansion on the right, right?
Posterior expansion on the left.
On the left, sorry. But you mentioned to activate the serratus anterior on the right side.
Right.
But they are external rotators, so they do expansion.
So the serratus on the right is important because think about what the right side tends to be winged a lot. You tend to see a lot of winged right scaps, just like you tend to see a lot of tibias that are turned out on the right side and a supinated foot on the right side. So remember what I said about the serratus anterior. Its job is to keep this scap on the rib cage. So we need to do that, and we need to have that scap come back and facilitate the ability for anterior expansion. And we can do that through a 90-degree reach with a protracted arm like this, because that is what's going to externally rotate the scap, and that's what's going to allow that scap to stay on the rib cage. And that's what the serratus anterior is helping accomplish.
But it's not something we also want on the left side to help the expansion?
It depends, right? So are we working with a wide or a narrow? If we're working with a wide, we probably do want some degree of serratus. Well, I mean, we probably want it in both cases. It just depends on the order of things. So reaches are going to be important for both people. It's just depending on the angle of the reach we're going for. So generally speaking, I'm going to want this. Actually, I'm probably going to want more serratus with narrows because they have those forward shoulders and winged scaps more often than the wides. But on the left, we don't want it as much and as early because we want that posterior expansion to occur first.
Okay.
The question was about the 2 people. I said, wouldn't they both have trouble? Or what did I write? Sorry, wouldn't both of these people lack posterior rib expansion? It was the picture of the guy with the retracted shoulder blades. You said he was a wide, and then it was the female with the wing scaps. Wouldn't they both lack posterior rib expansion? Yeah.
So it's relative. And I think this wide, it's pretty obvious that this person would be compressed here and lacking posterior expansion. But the left, this one right here they would have more posterior expansion because the scaps are being pulled outward. And it's different. These joint actions are different than, and this is what the biggest point of confusion, than these joint actions. Did you notice that? And that's secondary to the compression that's happening on the anterior rib cage. So I'm really glad you asked that question, Tyler, because this is what should happen when there's expansion happening 360 degrees within the rib cage. We should see these joint actions within the scapula. But because there is anterior compression, the scaps are pulled forward and upward, which opens up those scaps to allow for air to go posteriorly because it's not going anteriorly. So they have to find an inhalation strategy somehow.
Okay, yeah, because I was kind of seeing it as like there's like this, I was visualizing this space between the border, like that concave border of the scap and the convex angle of the ribs. And I was like, in my head, I was thinking like that space would be there because the ribs can't press into it, like when they're breathing. But you're saying no.
I'm saying that the rib cage is open because, well, the scapular position is secondary to the rib cage position. Okay. So I'm saying that their expansion is probably not going to be amazing, but it's probably going to be better than the wides because those scaps and the ribs are open on the back because it has to go literally somewhere. So it's not going forward and it's not going into their belly because of their IXA. So what they're probably going to want to do is push their head forward, kick on their neck, which is going to help them get air. But if they're also going to have more air go into that posterior rib cage, and the scapular orientation helps assist with that because they're being spread apart.
Okay. Thanks.
I have a question about, so if the shoulder blade behaves like a pelvis essentially, and the tricep muscle is a hamstring, so the like the humerus and like the humerus basically behaves like a femur bone, and then it's the same types of actions like from the lower body and like below the elbow, like behaves like the tibia.
You can make that, yeah, people make that comparison a lot. I think Bill Hartman makes that comparison a lot with the whole, the scapula. There's like 3 levels of the scap, 3 levels of the pelvis, just like we talked about with the scapula and rib cage levels. I don't go into the pelvis because I find like it confuses people quite a bit at first if they're just learning these things. So yes, the scapula and pelvis move very, very similarly, but there are differences, right? Because the scapula moves on an axis where, like, for example, if we're looking at 60 to 120, the scap is in ER, the humerus is in IR. Whereas when you look at the pelvis from 60 to 120, the pelvis is IR, femur is IR. But still, you're going to see a degree of internal rotation. You're still going to see more of like what I would call a compressive strategy from 60 to 120 than you would at 0 to 60 or 120 to 180. But yes, you can make a bunch of parallels. Like you could say the deltoid is the glute med of the shoulder. You know what I mean? Abduction. There's all these different parallels, and I think it stems from the fact that we used to be animals that walk on 4 limbs, right? So we're not that different. Like we're really far along from that, obviously, but our structure came from quadruped creatures. So we still have these parallels.
Could I ask one other question as well? It's probably a really basic question, but I'm a little bit confused about, like you were talking about how when you're lying on your back because of gravity, you're getting posterior expansion, but how does that work when you've got the compression of the floor? Because like on the wall, you were saying keep the upper back off the wall so you're not compressing, but I would have thought for like posterior expansion, you'd not want that sort of pressure pressing on the back of the ribs. So I'm just wondering what the kind of logic, I don't know, I finding it hard to resolve that in my head to make sense.
Absolutely. I had the same question when I was learning this stuff, and I would say it does make sense that if your back is on the ground, you're not going to get expansion because there's nowhere for it to expand into. But we also have to remember that if we're trying to get expansion posteriorly, what's happening to the viscera, what's happening to the organs, what's happening to the pressures. Imagine a water bottle. I wish I had one for you guys. Okay. If I do that, everything is going, I'm not going to spill it out, but everything is going downwards, right? So the pressure is going down. So if I lay on my back, everything's going to be pushing down, which is going to allow me to recruit that. And if I'm especially compressed there and I'm trying to get expansion, then I'm going to still get that expansion, but I don't necessarily need to press through the floor to get that expansion. I'm going to have it naturally occur through my rib cage. And actually, it doesn't need to move that much. You're still getting the expansion. And the reason why I said on the wall supported reach to keep your upper back off is because usually if people keep their upper back on it, they don't have as good of a reference to sense that posterior tilt. And since that's a beginner exercise, it's really good for someone to like really understand what their low back being pressed into something in isolation feels like.
Cool, that makes sense. I have one other question as well, just on the rotation. When you were speaking about, so I was kind of like trying to feel it when you were saying, am I correct in thinking you were saying when you rotate towards the left, the spinous process is turning right, so that's compressing the right, but then when you turn to the left, your left scap is adducting and your right scap is abducting. So I would have thought that then you're closing off your left with your scap at the back and you're opening up your right. So I'm also a little bit like, I just couldn't quite wrap my head around how the spinous process changed that as well.
Mm-hmm. Yeah, so look at, I think this image might do a good job. You see where these muscles attach on the spine? So if I were to turn my trunk to the left and you see the sets, then rotate to the right, that's going to bring my scap and shorten those, concentrically orient those muscles. It's going to bring them closer together. So therefore, I'm not going to get as much expansion back there. Whereas I'm going to get more so on the left posterior because that's eccentrically oriented. Whatever's eccentric is going to receive the air. That's the most important takeaway from that scapulohumeral rhythm idea. So by rotating our trunk to the left there, we're going to get more concentric activity on the back right. And if I'm reaching at 90 degrees, like I was in that seated position with a pronated grip, and I can keep my pec off, then that is going to allow me to get more anterior on the front. But this is the kicker. And I saw Ryan ask the question, how hard do you drive those reaches? As hard as they can keep their pecs off if they're reaching at 90 degrees, for example. So a big thing people will do, and I still struggle with this sometimes, is I'll have someone like a power lifter and I'll cue them through a very basic reset drill. And then they'll say, oh man, I'm lit up. I mean, what do you mean you're lit up? Well, it's because they're trying to like bench press their arms forward, or they're trying to reach down and squeeze everything together, and it goes totally against what we're trying to accomplish. So I will generally say, I want you to reach actively, but I want you to stay relaxed. I try to, honestly, something I've been saying a lot more lately is treating these resets as if they're like a meditative practice, as if, you know, these are trying to get you to downregulate your system. So I think when I frame it that way, I've gotten better results because people realize that they're not the same as a 1 rep max bench press, but that's what a lot of these people are used to doing. So that's how hard I will cue the reaches. And I really like unilateral reaches a lot of the time when we're going for 90 degrees, so they can keep the other hand on their pec and make sure it stays off. This is really powerful for forward reaches.
For somebody who can't, like, because I have a client at the moment actually with, like, when you were describing that, like, I'm not very familiar with PRI, but that right BC pattern, like, she breathes in and out using her neck almost exclusively, and like history of pelvic floor surgery and like loads and loads of different stuff going on. But like for her to turn her pec off, like we literally spent about 20 minutes of me just trying to be like, okay, unlock the elbow, change the angle of your arm, and literally nothing. You know, it was so hard for her to actually, you know, so I ended up just having her lying on her back, relaxing her arm. And even in that position, it was like, she's like, yeah, I still can't really turn it off. So like, is there any, like, would you say avoid 90-degree reaches in the situation like that? Just like try and take the muscle out of a range where it can actually do anything at all?
That's exactly right. Yeah, I would probably have them reach up if they can do that, because that's going to essentially orient the pec and lat. But also I'm going to put them in a side lying position probably, because they're not, like, side lying is just great for people who are so compressed. If you ever lost and don't know where to take someone, put them there, because that's what's going to allow gravity to act down and find that anterior to posterior expansion because of the lateral compressive forces of gravity. And I would say, even if they're narrow and super, super compressed, side lying is fantastic. So I'd say start there.
Cool. Thanks, Emil.
Mm-hmm. Can you go back to the Neil Holloman slide? Yes, I can. you have an additional question on top of that, Ryan?
Not on that. That was really good. But I had one more question. How would you distinguish or like between someone who's having a problem expanding the rib cage to get air somewhere versus someone who might have some kind of structural problem or an injury? I mean, obviously you can like look at their history and ask them questions, but how much do you take that into account, or what do you do to kind of distinguish between the two?
I guess the question would be like, what do you mean by structural?
Like someone might have a different reason why they might be restricted, I guess, just in general.
Yeah.
You know, whether it's the muscle tissue, it's an injury to the actual muscle, maybe tightening it up. I don't know exactly.
Yeah, I think the history is going to be really, really massively important with that. And then I will use that. And if I am doing something that I feel like should be working, and we've tried a bunch of things and that's not working, because remember, like the progression of like pelvis, thorax, not that, look at the foot, the neck. At that point, if I've done all that stuff and we're seeing nothing, then we know that there's something deeper going on within underneath the surface. And at that point, that's outside of my scope of practice. So I just would refer out at that point. And usually people are pretty open to that, because if you've tried things, you're not seeing results, like you gotta move along. Okay.
So you would just kind of like start with what you know about them, work on these things because you can change them. And if it's not working, you're like, I'm gonna, do what I can and refer out if I need to and stuff.
Yeah, pretty much.
Okay, cool, thanks.
I think the other Ryan had a question too. Or no?
Hey, Connor.
What's up?
I have a question actually. First of all, thank you for your time. And my question will be actually two questions. So first one, I'm new to PRI, and I'm interested in the FRC and stuff. And I know that you are more into PRI and you know more about that stuff. However, I'm just curious if you can combine those two practices together.
Oh, for sure you can. And I've never taken an FRC course, so I don't want to speak out of turn or out of a place of knowledge when it comes to FRC, because I'm not. So I think what I have talked to people though that do both quite a bit. So I feel like I can at least say this. What FRC does is they're trying to add range of motion to your system, but from what I understand, it's not a lot. They're not respecting the fact that the body needs to be neutral for that to happen. So if you're trying to drive range of motion on a system that is heavily asymmetrical, heavily compensatory, then what are you really getting out of that? You're driving compensation on a compensation. So maybe if we did some of these resets and got them neutral first, then we can drive that range of motion. Then we can drive those cars, pails, rails, whatever, because then the system's ready to accept it, and you're not driving, let's say you got a right scap that's super forward and a really forward right shoulder. What are you really getting out of that if you're going through end ranges of motion? What are you getting out of it if you're pushing envelope on that? So that would be my opinion. But again, never taken a course, so it's hard for me to be confident in that.
All right, thank you very much for that. And my second question was actually regards the last exercise that we've done. So as I mentioned, it's new for me. So first of all, can you explain me more what was the exercise for? And the second of all, maybe I didn't done something not correct. I'm more a narrow ESI. I felt the left side, but I didn't felt the right side. Maybe it was my breathing, and that might be the case. However, yeah, that.
Talking about this one right here.
Just give me 1 second. I'll just check it. Yeah, that's the one.
Okay. Yeah. So with this one, let's think about what the left AIC position is first. Where is my pelvis? There it is. Okay. Left AIC is here. Right side bias towards more nutation, towards more internal rotation, abduction, and extension. The left side is biased towards more counter nutation, external rotation, abduction, and flexion. So because of that, this position is going to be the inverse. And let's think about what the right AIC is. We're going to have a forward right shoulder, right anterior chest wall compression, left posterior compression, left anterior expansion, right posterior expansion. So this is literally the opposite of that. This is the pelvis going left, the pelvis going into hip extension on the left, going into adduction, internal rotation on the left. The left ab wall is being closed off, which is going to facilitate expansion of my left posterior rib cage and expansion of my right anterior rib cage and right ab wall. So this is just putting people in the opposite orientation of what is the underlying fundamental human pattern. And if you were feeling you said you were feeling your what instead?
I was feeling left side, but I didn't feel the right side.
You were feeling your left abs compressed, but not your right abs expand?
Yeah, that's true.
Usually what I see in that circumstance is, let me just hop on the floor and illustrate it. In that instance, what I usually see is they're probably too upright, they're probably here, because we want to have a degree of the left shoulder being lower than the right. We just don't want to do this. This is what some people will do. We want to be nice and upright. I feel this loosen up already. Exhale, yeah, hold on to these left abs. Pause, and then inhale. And you should feel like the air is going down.
Mm-hmm.
So maybe try that again with those things in mind might help you later. And if not, throw me a message in the Slack if that still doesn't work.
All right, thank you.
I have a question regarding this particular exercise. While I was doing it, my back left foot and tibia lifted off the ground. Is that supposed to happen?
Actually, that's technically a progression of this exercise. People will lift their left heel off the ground to get that anterior glute med on the left. But again, like these exercises, yeah, like that is not abnormal. I would say that's because you're getting that left adductor. But this position especially is like, I don't use things like this all the time because they're just, I don't know. I try to get away from the breathing stuff when I can. This is as necessary. But again, like this is PRI concepts, so we're using their exercises as well. But something like this, once you have someone in a left AIC pattern, generally speaking, you don't have to do a whole lot, especially if you peel back the layers. You can do something like this, but ultimately it's going to be about just managing your training stress and, you know, choosing exercises in the weight room that are going to help manage that. But yeah, if you're feeling your left foot come up, sorry, that was a tangent. Yes, that's not a bad thing.
In the left AIC pattern, on the lower half, we see, you can see increased hypertrophy in your left quad and left glute because it's pushing yourself over to the right. What do you see in the upper body then? What do you look for?
Usually a bigger left pec, nipple line that's higher on the right than left. You see that quite a bit. You see a left trap that's more hypertrophied. And you're also probably going to see right abs that are more developed than the left.
Yeah, because I'm just thinking about myself. Definitely bigger left pec, more concave on the right, which is what made me think the question, because you said concave on that side. And then whenever I'm working out, I feel my right obliques and abs going, but very rarely the left. When I do feel them on the left, it's a novel thing for me. And then, but the exercise you got on the screen there, you can feel that cramping up, and then eventually I started to lengthen out on that right hand side. So it's interesting feeling it.
Yeah. I love doing something like this before I go do like a bilateral exercise. Helps me get way more into my left and out of my right. Anything else?
I have a quick question going back to last week.
Yeah.
The center of mass from heel strike all the way to late stance is just going back to forward, right? I mean, I know it curves a little. So would it be that, like, if you're doing heel strike exercises and you're using a heel reference, or you're putting your heel in the ground or in the box, the same thing, like if you're working mid stance, you want the flat foot, maybe pronated. And if you want a late stance, you might have you could even have like a floating heel or like a toe forefoot emphasis or like a supinated emphasis. Is that right?
Yeah, it's all about the shin angle if you're trying to target a phase of gait. So
Okay.
if you guys, I had an Instagram post on this last week. So like you would do a toe elevation if you want to bias mid stance. You would do a heel elevation bias to bias heel strike, and you would do like a rear foot elevated position to get more late stance. Because when you do heel elevation, you're going to prevent that tibia from translating too far forward. And you're also going to bias that heel reference. When you go to toe elevated, you're going to pronate the foot, and you're going to bias them starting more of a vertical shin angle. when you're doing rear foot elevated, you're going to get that forward chin.
Okay, cool. Thanks.
So just regarding the 90-90, that position that's already on the slide there, I felt a really good expansion in my right ab wall and a really good compression in my left, but I couldn't really get a good feel my left adductor, and what ended up happening was my TFL just kind of lit up. So I know it's kind of a regressed like variation to begin with, but how would you maybe clear that up before you went to something like this?
Probably just something as simple as a left adductor pullback. You know what I mean? Just like that's the simplest answer. And also sometimes that person is not in enough hip extension, and sometimes they're in too much hip extension. So you might be in too much hip extension. That TFL is taking over for that adductor that can't do its job. Or you need to bring that knee further forward up to get a better sense of the ability to press into that floor and not stress yourself because maybe you're lacking left hip extension on that side.
Gotcha. Okay, thank you.
Can I comment on the beignets? I have tried also not feeling the adductor on the left side. I have actually used a pillow, so I get the floor up to me, kind of, instead of pushing it down. Just an add-on. Yeah.
I love that. Yeah. Thank you. You mentioned left trunk rotation causes right posterior compression, but then the left I see there's a left rotation and right posterior expansion. Could you clarify that? So left trunk rotation, right? So it's relative to the position of, it's like, think about it like this. So let's say, let me scroll back to this. You guys remember what I talked about with the scaps and what you would expect? You know, like this is what it is because of the compression going on throughout the and posterior thorax causes the anterior expansion. So what we would expect to see is this right here. Scapula goes inward. This is normal, right? But this is a result of the compensations. So what we're referring to within the left AIC pattern is that right scapular orientation coming forward like so. So because we have compression on the left, because we have left posterior, and because we have that compression going on within the respective ribcage chambers, we are biased into this position, which the diaphragm is also influencing these things. So it is, yes, I can see your confusion there, but it's a result of this position and orientation, which our pelvis also plays into. I hope that answers your question. Like this is what we would expect, trunk rotation, this is what we would expect to happen, but then you have what reality is based on the compensatory compressive strategies. My mind is... Thanks, Amy.
I ask one last thing actually, and again, it's relating to that same lady. It's just because I'm thinking out loud after what you were saying about reduced lymphatic drainage as well with that right BC pattern. Is that particularly on the right? Because like for her, she's literally like, she's all swollen around this like right part of her collarbone. Like it's like her right collarbone sits further forward. It's sort of like really prominent on this side, and then it's all puffy sort of around it. And like I'm not a doctor, and I was like, go to the doctor and see your doctor about it, but I'm just thinking, is that kind of like what you're describing? It's like that whole right side is so compressed with scalenes, SCM, pecs, everything, that it can't drain particularly from that right side? Or is it just a general kind of lymphatic restriction?
Yeah, I think that's also the reason PRI has something called superior T4 syndrome, which is where on the right side, because that right chest wall is so compressed, the scalene and other neck muscles will kick on to help elevate that right shoulder and also open up the first two ribs here, which in turn results in a neck that's cranked and even less lymphatic drainage, because that strategy is I need to open up this chest wall somehow. So that's usually what happens there, which also aids in that. So I would imagine that lady might have something very similar. So essentially they just need to drive air into this area. And I don't know, like, again, like we're not doctors, right? So this is like a slippery slope, but I would imagine if you could expand here, clear up this measurement, you would see some improvements there.
Okay, cool. Thank you.
Mm-hmm. Oh, and also AD dodging.
Yeah, she sucks at that. Like she's got none on the right.
Yeah.
I have one more question, if that's okay.
Please.
This is more relevant to last week. But so when the innominate, say your right innominate has externally rotated, what I learned in the past is that when the innominate externally rotates, relative the femur is then in more relative internal rotation. So then you have limited IR and have more ER at the hip. Does that make sense, or am I a little backwards?
I think it's backwards because think of like a narrower here, which allows them to access this. Wides are here, which brings the femurs inwards like this. So I'm not, maybe there's something else going on there. But usually speaking, when the pelvis tips back like this and ERs, you should have external rotation at the femurs.
So your hip IR measurements would be worse than your hip ER measurements.
Correct.
Gotcha.
Mm-hmm. Anything else? Good questions. Doesn't look like it. Well, I hope to see you guys at the review session on Thursday. Would love to have you there. Again, if you're ever confused, please throw something in the Slack chat with a question. I'd love to answer it. And thank you guys for your time coming today and sticking around till the end.
Thanks, Connor.
Thank you guys. I'll see you later.